Hello, my name is Matt Goebel. I'm an ER resident at Bay State Medical Center, and I'm going to be talking to you today about how to get better quality EKGs in the pre-hospital setting. There's three parts to this: skin prep, electrode placement, or where the stickers are going, and wire or cable management. What are you doing with all the wires? First, let's talk about skin prep. In order to get your EKG the first time, every patient needs some level of skin prep. For most patients, that could just be being aggressively wiped with a washcloth. Everyone has oil and other stuff on their skin that makes it difficult for the electrodes to make good contact, so everyone needs some kind of skin prep. Most men need to be shaved, especially if you've got those larger circular electrodes that most EMS providers are using. Don't connect your electrodes before you're ready to use them. As soon as you pull them out of the packaging, they start to dry out and they won't make as good a connection with the skin. So if you have pre-connected electrodes, just open a new bag, get some fresh ones on there. You're gonna get a better EKG every single time. Now let's talk about where most of the problems occur, and that's with electrode placement, or where the stickers actually go. Now, some common pitfalls are putting the limb leads on the chest. The limb leads need to go on the limbs. You can also inadvertently create problems if your precordial leads are off by more than 2 centimeters, which is less than an inch. When you do that, you can mask or create ST segment changes that can make an abnormal EKG appear normal, or vice versa. This EKG is abnormal. It's got a right bundle branch block looking pattern in V1 and V2 and some ST segment elevation there. This EKG looks normal. This is the same patient. The only difference is where the electrodes were. Here they are side by side. In the first one, the V1 and V2 electrodes were put up too high. They were kind of like up on the collarbone rather than down on the chest where they were supposed to be. Just as an example of the kind of changes that can occur when you don't have the stickers in the right spot. So let's talk about the limb leads. The limb leads need to go on the limbs, but what does that mean? For the upper extremities, that means anywhere past the deltoid. But also, the closer you can stay to the trunk, the less artifact you'll get. For the lower extremities, this means anywhere past the inguinal crease or the inguinal ligament. And again, the closer the better. But a lot of times, the ankles are the easiest place to get to, especially if they're wearing long pants. Now let's talk about where most problems occur, and that's with the precordial leads. The first step to getting your precordial leads in the correct location is to find the sternomanubrial angle, the angle of Louis, or the joint between your sternum and your manubrium. You can feel this on yourself by running your finger up and down the middle of your chest here, and you'll feel this little bump where it goes from your manubrium turning down into your sternum. And at that bump, you've also got the second rib joining in, and that's how you find the second intercostal space, which is your key to finding all of the other landmarks. Now, if you're having trouble feeling where this angle is on a patient, you can put a finger in the sternal notch and then put 3 fingers underneath it, and the bottom will be roughly where this level is. So you can find this angle, then you can feel the second inner space, and then you'll feel down for 3, 4, and then that's where V1 and V2 are going to go. We have to be mindful of bony landmarks for the horizontal positioning as well. Remember that the clavicle extends all the way out to the end of the shoulder, so midclavicular line is roughly equal with the areola or the nipple. And then in the armpit or the axilla, you've got 3 lines: the anterior, middle, and posterior axillary lines. And those are formed by the insertion of the muscles in the chest and back that form the actual armpit. So how do I apply and set up the precordial leads? Well, I'm going to start by feeling the angle of Louis and finding it by either feeling the angle or doing 3 of the patient's finger widths from the top of the manubrium. So then I'm going to find that angle, come out to the sides and fall. My fingers are going to fall into the second intercostal space. Then I'm going to go down to the third and feel in the fourth. And once I'm in the fourth intercostal space, on the right side I'm going to put V1, and on the left side I'm going to put V2. Next, I'm going to feel down for the fifth intercostal space, come all the way over to the midclavicular line, and I'm going to put V4. Then I'm going to put V3 halfway between V2 and V4. Now, the next one I'm going to place is actually V6. And the way that I'm going to place V6 is by finding the vertical level of V4 and going in a horizontal line perpendicular to the sternum, straight around the chest, all the way until I'm in the middle of the armpit. And that's probably further back than you think it is. Then we're going to finish by putting V5 in the anteroaxillary line, or roughly halfway between V4 and V6. If you're doing posterior leads, you're going to again follow that same level around the chest, except it's just that V9 is going to be right next to the spine, V8 is going to be basically at the tip or kind of in the middle of the scapula, and V7 is going to actually be like the posterior axillary line. For your right-sided EKG, this is going to all just be a mirror image on the other side. Let's talk about what to do with breast tissue. The problem with breast tissue is that you can move them out of the way, but then to apply electrodes to the chest wall, but as soon as you let go, the tissue is going to move and your electrodes won't be in the right position anymore. So it is better to place the electrodes directly onto the breast and let it stay, rather than try and manipulate the tissues to get them directly attached to the chest wall. And in this case study, they showed why. This patient had an abnormal EKG, a normal EKG, and then an abnormal EKG. And the only difference was whether they had put the precordial leads on the breast or underneath the breast. So here's another really good demonstration in this graphic here that you can lift the tissue up to put it on the chest wall in the correct position, but as soon as you let go, it's going to move out of the way. So it's better to just put the electrode on the breast so that it stays in the correct position. And I like the way that they paraphrase this. They said breast tissues are fake friends and definitively not a good point of reference. Now, it's not only a better quality, more technically correct EKG, but patients like it better. In this study, they had a bunch of paramedics put a bunch of EKGs on a bunch of female patients, and they asked them about their experience. And they found that women preferred electrode placement on the breast tissue rather than under, because it required less manipulation and felt less intrusive. So the last thing is, what do we do with the wires? Managing the cables and the wires. How do we eliminate that artifact that comes from that? You're probably familiar with this cable that connects all of your electrodes to your monitor. This is the point that divides where you create artifact and where you don't create artifact. Anywhere from the blob going out onto the individual wires, any movement there will create artifact. But going back to the monitor, where you've got that big thick cable, moving that doesn't create artifact. You can play jump rope with that while you're acquiring an EKG and you won't generate any artifact. So the trick here is to take the blob, and instead of what I did when I was a medic, where we have the monitor on the bench seat and allowing all the wires to just swing in the breeze between the bench seat and the stretcher while they're attached to the patient, move the blob all the way over to the patient so that the electrodes, those individual wires, and the blob are all moving as one unit as you're bumping down the road. And just that big thick cable is going back over to the monitor, and you'll get a lot less artifact that way. So to summarize, always prep the skin, either with at least a washcloth, if not doing something more aggressive to try and clean the skin. Don't pre-connect your electrodes. Get them out fresh every time so that they're going to be sticky and they're going to get a good electrical signal. Always palpate your bony landmarks, especially for the chest, starting by finding the angle of Louis. Move the blob or the box to the patient so that your electrodes, wires, and patient and blob are all moving together as one unit to reduce artifact. Now, this isn't a perfect EKG, but it's a perfectly readable EKG. And this was acquired on a patient by an EKG treadmill tech while the patient was walking at 2.5 miles an hour up a 12% incline. So anyone that tells you you can't get a diagnostic EKG in the pre-hospital setting is lying. If you use the tricks I've told you, you can get a good EKG every single time. Thanks.